So we come back to another common problem of earlier known as musculofacial anomalies, but now we are grouping them as congenital cranial disinnervation disorders, the CCDDs. So, and Duane's is the leader in the CCDDs. Hmm? So I have no financial disclosures. So Duane's retraction syndrome, as you all know, was first described by Hewitt, but these theory and all we can have from the books. We are not going to talk about them. The frequency is not uncommon. So we may see several of them. It's 1 to 4% of strabismus patients. Females are predominantly involved, 60%, and left side is more commonly involved. So that is an interesting thing which we need to keep in mind, and there is a very nice study which has come which explains that. 80% of the cases may be unilateral and left preponderance is there. So this is, as I said, in CCDD, a congenital cranial disinnervation disorder. What we mean is that here there is a primary disinnervation, absence of a sixth nerve or a hypoplastic sixth nerve, and there is a secondary disinnervation, that's an abnormal innervation by another nerve. Now this is the root thing in all the CCDDs, whether it is the Bell's palsy or whether it is the involving the ptosis and all. So Huber described it into type 1, 2 and 3. Type 1, as you all know, is the predominant one in which lateral rectus doesn't act during abduction, but it acts during adduction. Type 2 is one in which the lateral rectus is acting during abduction, but also acts during adduction. So, I mean, I generally like to say that it's like if you are sharing a room and there is two students, one of them doesn't study at all and doesn't let you study. That is a problem in Duane's. The other one is he studies himself but still doesn't let you study. That's a type 2. And type 3 is, of course, both of them are doing the same mischief. So when we have clinical presentations of Duane's retraction syndrome, we may have a esotropia in the primary position, and in this, what you see here, the left eye abduction is limited, and there is a narrowing of the palpebral aperture. There is an upshoot and downshoot happening on attempted adduction. So this is the classical picture of ESO-DRS. What is happening in the exo-DRS is that many common type 2 ones, exo in the primary position. Here the abduction is there. From here to here there is a movement. So there is some abduction. So but it is not as normal. But the main problem here is narrowing, upshoot and downshoot. The second type of sharing room. And the congenital cranial disinnervation disorders, what we meant was that in imaging you will find absence of sixth nerve compared to the controls. And there is paradoxic innervation. So this is the root cause which is causing the problem. And they may have ocular associations in the form of all this list. Important thing is the crocodile tears. If you ask the history, many of the children will say that when we eat or swallow anything, there is tearing. So when they have eating, then there is a swelling, and Marcus-Gunn jaw winking is another one. Systemic associations may be there in the form of all these cervical spina bifida, cleft palate, facial anomalies, and the syndromes, especially for the PGs particularly, you have to keep in mind the names: the golden heart, the Klippel-Feil, Wilder-Wunck, Holt-Oram syndrome, Oki-Hiro, and DRRS, and IVIC, the oculo-otoradial with thrombocytopenia. So these are having these associations of systemic problems, the Klippel-Feil here, and the Holt-Oram syndrome, in which there is also a cardiac anomaly which is there. Embryogenesis is a landmark article from my point of view. Parsa and Robert, you should all read this article from JAMA Ophthalmology 2013. He has described what is the reason why females are predominantly involved, why left side is more commonly involved. It's the higher estrogen levels and inflammation happening, a venous thromboembolic events which is happening in the 6 to 8 week of embryogenesis. So there are causes which we can probably control. Duane's may be avoidable if we can take care of these thrombogenic influences during pregnancy, malnutrition, dehydration, alcohol, infections, trauma, ionizing radiations in the first trimester. So, I mean, this is something which is different from our routine thing. Genetics is another thing. If you have, but majority of them are sporadic. So 80% of them do not have any genetic, on testing you won't get anything special. But otherwise the common genes which you may get through is the CHN1, the MAFB, the SOL4 and the HOXA1 genes. How do we manage these cases? Now this is the ESO, EXO and ortho. First of all, you have to see whether it is an ESO, EXO or ortho. Second thing is that co-contraction very significant. Co-contraction by rule is always there. It may be mild or it may be more severe. So our management will depend upon that. Third is how much is the LR activity? Is it normal LR activity or reduced? Or, and the fourth point you have to note is force reduction test positive for MR and LR or for both. Now let's take some examples. This is an ESO DRS. FDT is positive for the medial rectus here, as you can see here, and minimal co-contraction is there. So in such a situation, a single medial rectus recession of 4 millimeters, you have to be very homeopathic in doing medial rectus surgery. Lesser is better. If you do a little more, you may create a synergistic divergence excess. So you may create a iatrogenic synergistic divergence. So be careful about the MR recession dose. Be very according to the FDT. If it is tight, you have to recess it, but the minimal required for recession intraoperative FDT should be done. A little more will cause that. So if you have a significant co-contraction and you have to do more MR recession, you would have to balance it with the LR recession. And this lateral rectus Y-split recession is done. So we may do in such cases a MR recession along with an LR recession. Both are recessions. So in ESO DRS, do the minimal MR recession required as per the FDT if the MR is tight. Second is when you have to balance with the lateral rectus recession, you can do a Y-split. Mind you, the Y-split is what takes care of the upshoots and downshoots. And it is the recession which takes care of the narrowing of the palpebral aperture. Both are two different components of the surgery. If you do a Y-split without recession, you would not get an effect of narrowing of palpebral aperture being improved. Only the co-contractions will be taken care of. So both have to be done accordingly. And you may improve the abduction by doing SRT, IRT or whatever, but prior thing is first you have to neutralize the paradoxic innervation of lateral rectus. Now unilateral recession and resection. Now this is the anathema of what was being talked about. Resection should not be done. You have Dr. Stephen Kraft talking about the resections. Yes, in very selected cases it may be done, but remember, even in the published articles by him, you will see that there is a problem. There is an exo which becomes more, and there is a narrowing which becomes worse. So you have to be careful, and he has also advocated never do more than 5 millimeters, and the LR resection should be about 3 to 4 millimeters, MR never more than 5 millimeters. If there is an ESO DRS in which FDT was free and there is a minimal co-contraction, then one can do just an SRT, and that will improve the abduction, correct the ESO without worsening the co-contraction, which is very minimal in such cases. So a single muscle of superior rectus transposition may suffice. So this planning of algorithm is there in an article by us in IJO. You can go back to it. This is showing you an algorithm. Now in exo DRS, what do? You have to decide on the basis of how much is the exotropia in primary position, how much is the co-contraction, which is usually very severe, and how much is the LR activity. Is it normal or is it not there at all? So some procedures we can do only if there is no normal LR activity. But if there is a normal LR activity, one should not sacrifice the lateral rectus abduction. So don't do periosteal fixations in cases in which there is some LR activity. Then we will do an LR recession with Y-split. So here the exo DRS, 12 millimeter lateral rectus recession with 21 millimeter of Y-split. Now these numbers you have to keep in mind. A Y-split should be minimum 22 millimeters. If it is done less, as shown in many of the figures in books, it will not work. So you have to do good amount of that, because that is what is correcting the upshoots and downshoots. And the recession, as I said, will depend on the FDT of the lateral rectus and the exo deviation in the primary position. So you would have to do as much as required. So in this case, we did LR recession of 12 mm with 21 millimeter Y-split, and here you can see the correction is there. So this is what you can get. Do we need to see this video, or we can skip this? So in just reverse of medial rectus, lateral rectus recession, little is no good. Here you have to be non-homeopathic. You have to be very proactive and do as much required, because the lateral rectus is the culprit. It is the problem. Never leave the terrorist with little bit of kicking. You have to take care of it, and that's why we do periosteal fixations in cases of very severe co-contractions in which the LR activity is not there. So he is not of any use. What do? We put him in the prison forever. So that is the compartmentalization of lateral rectus, periosteal fixation. And to improve the abduction, we can do the partial VRT or any other procedure. So the periosteal fixations of the lateral rectus, just see this, what is done. So you will choose only those cases in which LR activity is not there at all. Then you will do the periosteal fixation of lateral rectus. So here the LR is very tight, it's being hooked. So this is loose. I think loose है कुछ. यहीं से हिला शायद. So in exo-DRS, when we are doing, we have to be taking care of the normal LR activity. If there is an LR activity, choose to do an LR recession with Y-split. If there is no LR activity, then we will do a periosteal fixation. So, and if there is an ortho-DRS, which is the most complicated type of DRS, many a times we would like to leave them to the opponent, to the other people, send it back to another person who will face the music. But if you have to be the person who has to finally take the call, what will you do? Then you can do a adjustable MR recession to control the ESO effect and the LR recession with Y-split. So that will be the take on the DRS types. So mostly we have, and to improve the abduction,